Oh, yeah. Can you just present? You guys can sit down, but it's fine. Okay. Everything all set? Sir? Yep. Okay. Assalamu alaikum, everyone. Good afternoon. How's everyone doing today? You guys seem so awake and energetic and full of life, huh?
Yes.
So today we're going to talk about some topics. And honestly, I'm not just saying this because I'm teaching them, but in my opinion, these are some of the most important topics for your midterm and for your step one. Inshallah, this information, if you remember it once, you'll remember it down the line. And that's the really cool thing with this. So we're going to talk about the cortex, and we're going to talk about the homunculus, which is some ugly dude. The cerebral artery, circle of Willis, which is cerebral arteries again. Venous sinuses, which is just cerebral veins. The ventricular system, and then we'll go into pathology. This seems very overwhelming, so it's a lot of objectives. We'll put it down into three simple ones. The structural and functional anatomy of the cranium, the vascular and fluid components, and then pathologies. That's a lot more simple, صح? Great. Let's move on. Why do we learn about the cerebrum? Why is the cerebrum such an important topic clinically?
It's a whole brain.
It's a whole brain. But my question is, why do we need to learn about the cerebrum? What could go wrong?
It's the motor part.
By the way, you don't need to raise your hand, just blurt it out.
It's the connection between everything, like all the signals, to what we actually want to, how we want to function as human beings.
You're absolutely correct. But what can go wrong? Why do we need to learn about the cerebrum? Stroke. What else? Tumors, epilepsy, hemorrhage, absolutely. So a lot can go wrong, and we'll talk about that in pathologies. So I'm going to give you guys a scenario. This is your question. Basically, let's take Philos. Philos came, not Philos, someone older than Philos, صراحة. Let's take, sorry? No, not that old.
37, I'm 37.
No, 37 is still too young. Let's say, okay, 50-year-old male comes to you with a headache. What are your differentials? Stroke, cancer. What else? Migraine, absolutely. For what questions would you ask history-wise?
Where is it localized?
Where is the headache? Absolutely. What else?
When did it start?
What else?
How did it start?
What makes this headache different?
What makes this headache different? That's a very good question. What else?
How did it start?
Very good. What else?
Is it getting worse with time, or what about pattern?
Worse, better. Does it follow any pattern? Absolutely. What else?
Vision problems. Oh, right. Jerking.
You sure? But
Associated
symptoms, other pain, parathesis, whatever, right? So if I told you guys he had a headache, it started after he argued with his wife. He felt it, and he generalized, but he also felt that his left face was drooping, and his arm was weak.
Stroke.
So you think stroke? Absolutely.
Those are PBL.
Yeah. I had no idea. Okay, look, I remember a lot from Neuro, but not that much. But okay, so stroke is one differential. And you guys said a lot of them. And honestly, no one said it, but I was hoping someone would say lupus. I had this whole animation prepared, Salaha. It didn't work out. But this is something I do in my clinical years. We have a lot of, by the way, when you guys get to your clinical years, you'll have so many presentations. So I always make sure to include this particular slide. And it even has the Vine boom sound effect, yeah. But it's never lupus. Although lupus can cause headaches. Okay. Cerebral cortex. What do you guys know about it? It has 4 parts. What are they? Frontal, parietal, occipital, and temporal. Very good. So frontal, what does it do? Decision, essentially, more generally.
Motor function.
Very good.
And cognitive behavior.
Motor function, cognitive behavior. Let's just call it lots of people refer to it as the motor area. But let's stick with that. Parietal. Sensation. Very good. Temporal. Auditory. And then occipital. Very good. Now, you guys, by the way, a lot of this information you'll already know, but the brain itself, the gyri and the sulci, they divide into areas called Brodmann areas. Now, Brodmann is just some random guy. And the numbering is, honestly, it's very skewed. He didn't number them by function or importance or whatever. He just numbered them by vibes. So, for example, 4 is like the primary motor cortex, but the primary sensory is 1, 2, and 3. The guy was just bored, honestly. Plain. Now, most of these lobes have a blood supply, which is the medial cerebral artery, right? Which one isn't? mainly supplied by the middle cerebral.
The lower limb of
The occipital lobe. This thing.
Posterior.
Yeah, so the posterior part of the brain is supplied by the posterior cerebral artery. Great. Now we're going to do an activity. Played. Now, I know you guys probably know the broadened areas, so there's no point. But if anyone wants to take a paper, go ahead. If anyone wants to write on their phone, go ahead. But we're going to do an activity. So we're going to go cortex by cortex, and we're going to list out the broadened areas. Your one job, the one thing I'm asking you guys to do, is write down what can go wrong. Because in neuroanatomy, you need to know what is the structure, what does it normally do, and then as clinicians, inshallah, all of you guys will become doctors in 3 years. And believe me, it will happen way quicker than you think. But the other thing is what could go wrong. All right, so let's start off with these areas. So this is the frontal. Now the frontal, you have the primary motor cortex, and the function of this is contralateral motion. So write down what you think could go wrong, and just write down all of these. If you want to read off the slides, go ahead. I'm going to explain, and when you've written down what's wrong, we'll move on to the next. And at the very end, we'll summarize. So, primary motor cortex, I said, Brodmann area number 4, contralateral motor function. The premotor cortex, contralateral coordination of movement. So this is important for sequential movement. And then we have something between them called the supplementary motor cortex. So if Brodmann area 4 or 6 gets damaged, this cortex will replace them. Then we have Broca's area. Broca's area is responsible for initiation of speech or comprehensive word formation. And then we have the frontal oculomotor cortex. This is responsible for something called voluntary, saccadic, conjugate, horizontal gaze. And I'll show you guys a video of it at the very end, which is over here. And then we have the prefrontal. The prefrontal, this is all the way at the front. These areas over here, they're responsible for executive thinking or executive function. Okay? So have you guys written what you think could go wrong with each part, or do you need like maybe a few more seconds? Just write down what could go wrong. 7.
I wanted to answer the
Well, we're going to do them at the end. So I'll assign each person to one cortex. Or each person to one Brodmann area. I don't know, we'll see the vibes. Play. Let's move on. Bis Hashan, I don't want to take too much of your time. And hand parietal. By the way, frontal cortex has the most Brodmann areas that you need to know. The rest are all easy. Parietal has 3. The primary somatosensory. So it's like the primary motor, just sensory function. So that's 1, 2, and 3. Somatosensory association complex is stereognosis. Now, does anyone know what stereognosis means? Go ahead. Sorry?
No, that's the
being able to touch.
Being able to do what by touching?
Recognize an object.
Very good. So being
Your
able
eyes
to.
closed.
Sorry?
Your eyes are closed and you feel an object and know where it is.
Exactly. So you're able to tell by shape and by size. So for example, I hold this battery. If I close my eyes and my somatosensory association cortex is in chat, I'm like, okay, Incan, this is around maybe 1 inch, 1.5 inches, and it's a cylinder. That's stereognosis right there. All right, and we have the major association cortex. We have 2 areas, the angular and the supramarginal gyri over here, and these have connections to the occipital lobe. These have connections to the temporal lobe. So when I say major association cortex, what do you think the function is? I mean, what do you think could happen if it's connected to all these other cortices?
Communication.
Very good. Communication of the different tracts so that you get all sensations, both general and special sensation, will go through this area. And based on that, you'll do a motor function or just do nothing. And then one thing to keep in mind is the lesions do depend on something called hemispheric dominance. So what do I mean by that? What's hemispheric dominance?
Which hemisphere is dominant?
Exactly. So most people will have what dominance? Right or left?
Left.
Left, and as a result, they'll have what? Right hand. Yeah. So it's like 90 to 95% versus 5%. Then we have the temporal and occipital. So in temporal and occipital, you have the primary auditory for sound, the secondary auditory for comprehending sound, and then Wernicke's area. Wernicke's area has parts in the parietal lobe. The idea is to just integrate senses. Right then we have the occipital. You have the primary visual for vision and the secondary visual for interpretation of information. Do we need to go back to any Brodmann areas? Do we need to go back to anything? Well, you guys think we can ask what could go wrong? Let's ask. Okay, so I need a volunteer. Nama, go ahead. So primary motor cortex. If there's a lesion here, what could go wrong?
Primary motor, you can't move a limb or weakness in the limb.
Very good. Which limb?
Yeah.
Yeah, contralateral to the side of the lesion. Very good. Next, who's gonna vote? Jenna, go ahead. Let's go with prefrontal cortex. What could go wrong?
The one thing that I didn't write down.
Okay, what did you write down from this?
The premotor.
Premotor, tell me.
It's like you can't coordinate your movements.
Very good. On the contralateral side, do you know what the short name for this is?
Ataxia.
Apraxia. Very good. Okay. Next, Filas, go ahead. Supplementary motor cortex.
Supplementary, isn't it also similar to premotor cortex, like apraxia and just general motor problems?
Yeah. So
Can't
basically,
initiate.
so not exactly. It's like so it basically imagine. It depends on the area it's replacing. So if it replaces an area and then it gets damaged, because I said it can replace 4 or 6, right? The function of 4 is contralateral movement. The function of 6 is contralateral coordination of movement. Depending on what it's replacing, that's where it goes wrong. You will not get questions on this, by the way, so don't worry. طيب, Broca's area.
Sorry.
No, go on.
Oh, okay.
No, you're.
Unfluent aphasia. So he's like he understands what he's saying, but he can't form the sentences. So
Exactly.
It's broken up.
Exactly. I call this bro can't talk. Okay, frontal oculomotor. What would go wrong?
Visual, what exactly?
Well, basically, there's a YouTube video. Honestly, if I explain it to you, it's not going to make sense. But
Is it like a horizontal gaze?
it does move to the side of the lesion,
Okay.
and yeah, it's like frontal eye field. So it's like tracking, for example.
It's internuclear ophthalmoplegia.
That's medial longitudinal fasciculus, different structure. But I like that your brain is working. And you know stuff, mashallah. Like prefrontal, what could go wrong?
Motion.
Thinking.
Emotions, mood swings.
Exactly. Emotions, thinking, mood swings. A lot could go wrong. Okay, primary somatosensory
Numbness.
Okay.
Contralateral.
on contralateral side. Thank you, Manik.
Whenever we talk about the cortex, it's always contralateral.
Almost always.
When is
So, for example, with Broca's area, it's not really it's not something that localizes. Some of them don't localize, some of them are contralateral, some of them are ipsilateral. So frontal oculomotor is ipsilateral.
Yeah.
But the rest of them are all contralateral. Prefrontal doesn't localize, Broca's doesn't localize. طيب. Then we have primary somatosensory, so we said numbness on the contralateral side. So somatosensory association complex. What could go wrong?
You can't do stuff.
And what's that called?
Asteria.
Astereognosis. Very good. The A means it can't. And then major association cortex. What could go wrong?
Or Gertzmann.
Sorry?
Gertzmann syndrome or Hemi.
Very good.
Depending on the
Absolutely. Gerstmann or hemi-neglect. It's like, what is Gerstmann?
It's affecting word cues.
It's a bunch of symptoms.
What are the bunch of symptoms? All right.
They can't calculate.
They can't do bait. Okay, so I got a lot of UWorld questions about Gerstmann syndrome for some reason. So basically, they'll give you a guy who can't do math, who puts his left shoe on his right foot, so he has left-right confusion. Finger agnosia, so he doesn't feel his fingers, like he's moving his fingers randomly. He can't do basic math. These are all symptoms of Gerstmann. What about hemi-neglect?
Shave like the whole side of the body.
Exactly. So Gerstmann, let's say, la qadarullah, one of us got Gerstmann. Which hemisphere would be affected? Sorry?
Dominant.
Oh wait.
Which one? Left or right?
Left, yeah.
Yeah, so if it's a left, exactly. So most likely, if someone has Gerstmann syndrome, the stroke could be in the left brain. And then if they have hemi-neglect,
Right.
the right. Now, could you make this assumption and not get sued? No. You must confirm. Like, and that's why they do CTs. They don't just like call us by vibes. Anyways, temporal. So primary auditory, what could go wrong? Shabab al-Bak. What could go wrong? If take function, basically the trick with this, take the function I've written down for you, strike it out. So what could go wrong if the primary auditory cortex is broken? Can't hear. And then secondary auditory. You can't recognize the voices coming specifically, can't understand, very good. And then Wernicke's area.
It's similar to broken, like you can't really speak properly.
But you're not
aware.
aware.
It's
But
different.
you're not aware of what you're saying.
Exactly.
The
It's
words are
fluid.
not making sense.
Exactly. Oh, there's a table that's going to clear all of your confusions, by the way, for in terms of specifically for the aphasias. Because there's another aphasia that's not written here. Do you guys know what it's called? Conduction aphasia. It's damage to something called the arcuate facilicus, which connects Wernicke's with Broca's area. But see, we'll get to that in brain pathologies. Okay. Occipital. So primary visual cortex, what could go wrong?
Can't see.
Can't see where?
Like,
Not bitemporal. Bitemporal is something else.
Homonymous hemianopia.
Contralateral homonymous hemianopia with
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 macroscopic.
Why?
Because it's supplied by
dual supply. Very good. And then secondary visual information.
You can't recognize things yourself.
Exactly. So I look at philosophy. Oh, that's lemma. Anyways, here's a table. I made you guys work al-fadi, but honestly, when you write it down, when you say it out loud, you have this table. This is I have a bunch of like neuro tables. I don't mind sending them to you guys. But this table right here summarizes everything we've spoken about. All right. And then if you're wondering what VSCH, I forget this all the time. This is voluntary saccaded conjugate horizontal gaze. I did that without looking. Anyways, this ugly guy. All right. Honestly, I feel kind of bad, but he is really ugly. Honestly speaking.
No. What is wrong with him? Look at it. He doesn't have hair.
He doesn't have a lot of things, not just hair. Anyways, I don't know why they didn't make a cartoon out of it. Maybe he could have definitely been a Disney villain, I'm sure. But anyways, like in like the Seven Dwarfs, like if they made like a second one of like Snow White, the homunculus. He was the eighth dwarf or something. But anyways, let's stop roasting the guy. But the idea behind showing you the homunculus is we have something called the motor and the sensory homunculus. Where do you think this ugly guy is? Which lobe?
The motor.
Motor. Which Brodmann area?
4.
4. Very good. And then this, honestly, more ugly guy. Like the sensory one. Where is this?
1, 2, 3.
1, 2, 3. Very good. 1, 2, 3, 4. So basically, the idea behind showing you this is we said one of the things that can go wrong is stroke. What's a stroke? Yeah, and we have 3 kinds of cerebral strokes that we talk about, which are no. I mean like by blood vessel.
Oh,
So posterior, middle,
anterior.
anterior. Very good. So in an ACA stroke, for example, the ACA supplies the middle, like the middle of the brain and the front of the brain. So if you had an ACA stroke, the legs are going to be affected. And then, for example, or not even just that. For example, in some herniation syndromes, it compresses on the ACA, and as a result, the legs will get affected. And then in the MCA, it supplies the face, and the face as well as the arms and the upper limb. So in an MCA stroke, for example, like our patient, he had facial weakness, and he had left facial weakness and left arm weakness. So he had an MCA stroke, right? Right or left?
Left. Right. Yeah.
Right. If he had left, that means this is broken. All right. So for some reason, the contralateral stuff gets confusing, but once you get the hang of it, خلاص. Okay, so we have questions. So it's 4 questions, basically seeing if you know what each area does. So I need a volunteer. Nama, go ahead.
Reduction of speech as well as visual function of
So this one's a little bit tricky, but it shows that you understand secondary functions of this. Do you want to try again? Frontal. Because production of speech, where did we say what initiates speech? Broca's area. Because if you have a Broca's area, Bro can't talk. And then visual function. I didn't say like seeing in general, just visual function. Frontal eye fields. Voluntary saccaded conjugate gaze. So this is just showing. I know it's a very weird way of asking about the frontal lobe, but I wrote questions harder than the exam actually is, so that if you guys can solve this, you can solve anything. Okay, what about this? Integration of somatosensory process. Who wants to volunteer? Shakshak, you want to volunteer. Alright, thank you, Victor. Parietal. You'll get the next one. General vision is a function of which of the following lobes? Occipital, very good. And the last one. There is a 4th question. Kika. Oh, okay, here. This one. Temporal, very good. Okay, great. So that's the first objective done. Second objective is circle of hooks. Now I need to spend some time here. We need to talk to you guys about this circle of hooks. Okay, my question is this a normal structure in the human brain?
No. Yes.
Who says yes? Who says no?
What?
You said yes and no?
Yeah, I'm not sure.
Okay, we've got to pick a side. So raise your hand if you think this is normal. And raise your hand if you think it's abnormal.
I mean, the rest of the brain isn't there. Is that what you're
No. Trust me, I'm not talking about like that. Like, is this something that occurs in the majority of the population?
Majority, yeah, but it's not in everyone.
No, it doesn't even occur in the majority.
Really?
25% of people have a complete circle of willis. Now, this structure exists in everyone. It should, but it doesn't exist in the full form. For example, this communication might not exist, but you still have all these arteries. And this communication may not exist, but you still have all these arteries. So only 25% of the population has a complete circle of willis. And the thing is, the structure is so important because of this, it actually prevents strokes. Because you have a lot of collateral supply. Okay, so we had three main cerebral arteries, which were what?
MCA,
ACA, MCA, PCA. Very good. So this is the PCA, this is the MCA, this is the ACA. Over here. Right here. These two. Like this connection right here is the ACA. Slightly thin. And we said that the MCA supplies the lateral brain, the ACA supplies the medial brain, and the PCA supplies the posterior brain. Alright? So most of the brain is supplied by the MCA, like we said. So this is the lateral brain, and then the front as well as the middle is supplied by what? Anterior, very good. And the back is supplied by what? Posterior. So, and we said if we have a posterior cerebral artery stroke, what could happen?
Vision.
What's the vision loss called specifically?
Homonymous hemianopsia.
Contralateral homonymous hemianopsia with?
Macular sparing.
Because which artery supplies the macula?
Another one.
We're going to be repeating a lot, by the way, but this is just to get the concept stuck in your head.
Which one did the ACA supply?
Sorry?
Which part of the brain did the anterior one supply?
Good question. The anterior parts of the brain is supplied by the ACA as well as the medial parts of the brain. Let's draw it up. You know what? I asked them for markers just in case I need them. Let's go through it. Okay. This. Let me see. Oh, this is really good. Okay, I'm not gonna draw all this, but can you show this around, for example. So show this here. But essentially, this is actually a very important picture. If you could share it with everyone, that would be good. I have a picture as well in my slides, but this is a really good picture that explains the different territories. So yeah.
Share it with the professional.
Just send it to me. I'll send it to Yanni. I'll send it to team. Okay. So yeah. Now the MCA, PCA, ACA. Where do they come from? What's?
Basilar artery.
No.
You guys are saying a lot of arteries.
Internal.
Internal carotid, absolutely. So let's say I blocked up the internal carotid. What do you think would happen?
Stroke. And everywhere.
The guy would die. Not even just strokes. This, the idea is none of the arteries get supplied, so all the territories would be affected. That's a weird thing. You won't get asked about it, but it exists. Rarely, but it does exist. Okay. Now, for example, you have these arteries over here that supply the cerebrum. What about these arteries over here? Brainstem, very good. But there is an artery here that supplies both the brainstem and the cerebrum. What is it? Posterior cerebral, very good. What does the posterior cerebral supply in the brainstem? In the brainstem? Midbrain, very good. It supplies the midbrain. And that can cause lesions of what cranial nerves? 3 and 4. Yeah, 3 and 4. Very good. Trochlear and oculomotor. Alright. So the question is, in a if you get a question about someone who has a PCA stroke, how do you know if it's a brainstem stroke or it's a cortical stroke? What do you guys think? I want you guys to take a knock at this. Features, yeah, absolutely. Yeah, but what's the difference in presentation?
If it's a brainstem stroke, it would affect the facial.
Yeah.
Clinical is just a midbrain. It's just a midbrain stroke versus PCA, PCA cerebral stroke.
PCA will be having bitemporal. No.
Yep, not bitemporal.
Hemi something.
Contralateral homonymous hemianopsia.
Yes. And
Okay, great.
And the midbrain will be the muscles of the eye will be affected.
Very good. So you mentioned an important point, muscles of the eye. So if it's a midbrain stroke, there won't be vision loss per se. Rather, there will be a gaze palsy. So the eye itself can't move. But if it's a cerebral stroke, the patient themselves can't see. So that's a very important feature. Brainstem strokes will not have cortical signs. And I'll get to cortical signs when I talk about strokes, but yeah, that's something important to remember. This is what the circle of Willis looks like in the imaging, and you can see the basilar artery, and this is the basilar artery is part of which blood supply for what part of the brain?
Posterior.
Like the posterior brain, which essentially is the brainstem. I mean, it's a posterior circle of Willis, so brainstem, and then you have the MCA over here. You have this PCA over here, the ACA over here. Okay, you know what? I remember. I just got flashback of some trauma that happened. Out of context, that sounds terrible, but all right. So I got a question when I was prepping set one. So basically, the guy had right lower leg weakness. What does that mean? Due to a stroke. Which artery?
The anterior.
Left anterior. Very good. Okay. The question wasn't asking me. One of the options was anterior, but it was two anterior. It was anterior distal to the anterior communicating and anterior proximal to the anterior communicating. I was like, what the hell? I was confused. I was lost. I had no idea. So let me point it out to you guys. This is the area distal to the anterior. This is the anterior communicating over here. This is the area distal. This is the area proximal. So what do you guys think? Which one? Okay. No. Don't joke. Tell me why you think it's proximal, and if someone thinks it's distal, why you think it's distal.
Distal, because if proximal is blocked, then it will be supplied by the collaterals.
Okay, that's your argument for distal. What about proximal? Like why would it be proximal? Okay, so you're right. It is distal, mashallah. Now I didn't know that. I still guessed distal. Alhamdulillah, I got it correct, but I didn't know that at the time. So what's the important concept before? So we'll finish the circle of Willis. The blood flows like this in the anterior, and the blood flows this way for posterior. So the blood is the blood flows anterior in the anterior part and posterior in the posterior part. So the blood that comes from the internal carotid to the anterior cerebral is going like this. It's going this way, right? So the idea is the blood has to go this way. If this part of the anterior cerebral is blocked, that's okay. The blood will flow here to the area blocked, which will only a half. But distal, there's nothing. Khalas. After communicating, khalas, doesn't connect. So if it's blocked, it's blocked. There's going to be a stroke. Good question.
Didn't we say that the circle of Willis is not present in everyone? So not everyone has
Exactly.
collateral support.
Exactly, because people who had this are less at risk for strokes. You're absolutely correct. But in, for example, USMLE, they want to just assume normal circle of Willis. But good question. I guess we could go ahead.
Anterior to the communicating is just the anterior cerebral. So
This is all anterior cerebral, but it communicates at some point. But it's still anterior cerebral. بالضبط. Alright, so his question was, is this all anterior cerebral? The answer is yes. Okay, this is essentially everything we've said. Medial anterior brain by ACA. And then, for example, there's other functions. So the what controls our smell? Olfactory nerve, which is what? Cranial nerve 1. And this is in the medial part of the brain. So we said the ACA supplies medial brain, and it supplies olfaction. So what could happen if there's a stroke? Loss of smell. Very good. What's this called? Anosmia. Excellent. Right. And then it also affects the medial parietal lobe, the part specifically which affects the urinary bladder. I'm not going to go back to the homunculus because we all probably ignored that. But the idea is, if there's a stroke, what else could we see? Incontinence. Excellent. Right. Lateral brain. So we mentioned it supplies the homunculus supplies the upper limb and face, coordination of movement, frontal eye fields, but it also supplies sensory. So we said that it's going to affect the parietal lobe. It could affect the major association cortex. So what could happen? The two syndromes. Gersman and hemi-neglect, exactly. So sometimes in questions they'll ask you about a patient, and the only thing they'll tell you is he has Gersman. He has a stroke and he has Gersman. What artery was affected specifically? Which MCA, right or left? Yes, left.
Yes.
Because the left hemisphere.
We just assume that was right.
What we shouldn't, look, clinically speaking, don't assume. The idea is Gersman. So Gersman, if there's a lesion of the dominant parietal lobe, we'll have Gersman, right? Most people have dominant parietal lobe, dominant parietal lobe is right or left?
Left.
Left. And as a result, they're right-handed. So the idea is, if someone had a stroke which affected the parietal area, the left parietal area, they, in theory, would have Gerstmann. That's the idea. And then they want you to make these very obscure connections sometimes, but they make some sense. Jenna, go ahead.
Can you say it again?
Absolutely. Okay. So, if we had a stroke of the parietal lobe, depending on the dominance, it will either cause Gerstmann or hemi-neglect. صح? Most people, the dominant lobe is what?
The left.
The left. So, if they had a left MCA stroke, which affected the parietal lobe, as a result, they would have what? Gerstmann. Very good. And if it's a right MCA stroke that affects the parietal lobe, hemi-neglect. Very good. Got that? Great. And then PCA, like we said, contralateral thermometer hemianopsia with macular sparing, whatever. I get it, Dharma. Anyways, but it also supplies the temporal, and if it's affected, it can affect the person's recognition of people and memory. This is called prosopagnosia. Very weird, but good to know. That's the main blood supply. We have areas called watershed areas. What is a watershed area?
Drains. They're
It
not.
acts, there's
No collateral.
there's not really overlap. It's weakly perforated by the cerebral arteries. So you have an area where the MCA, ACA territory are connected. This area is watershed. And the area where the MCA and PCA territories connect, this is watershed. What do you think would happen if, for example, this person went into heart surgery?
These would be the first to be affected.
Thank you. These two would be the first to be affected. And there's other parts of the brain which would also be affected, like the hippocampus, the basal ganglia, the hypothalamus and thalamus, and the cerebellum. Now, another thing that the USMLE wants you to know is that you have watershed areas in the abdomen, in the splenic flexure, and the rectosigmoid junction. So this is very random, but important information just to connect the whole picture. Then sometimes I'll ask you, for example, a patient went into surgery, and then all of a sudden their splenic flexure collapsed, or there was a stroke, there was a ischemia of the area supplied by the splenic flexure. What parts of the brain would be affected, and they'll give you an image, and they'll want you to point out to these two watershed areas, or the hippocampus, or the basal ganglia, or whatever. Then we have dural venous sinuses. There's not much else to say besides they exist. The superior sagittal sinus takes from the superior brain, and then the straight sinus and all these over here, the inferior sagittal sinus takes from the medial parts of the brain and the inferior parts of the brain, and then they all connect to the confluence of sinuses, and then it goes to the jugular veins. If you understand the words on this picture, there's not much else to understand, really. There is something called sinus thrombosis. So we have venous and then specifically cavernous sinus thrombosis. So cavernous sinus thrombosis is very important for the step 1 because usually it's due to an infection and it causes cranial nerve lesions. So 3, 4, V1, V2, and 6. Now this isn't a brainstem lecture, so I won't go into what each single palsy does. But if you see a bunch of cranial nerve lesions, all right, in a patient who you think could have an infection, the treatment would be antibiotics. Very weird, but it's random information. Venous sinus thrombosis is not an infection-related cause. It's due to hypercoagulability. It presents with signs of high intracranial pressure. Do you guys know what the signs of high intracranial pressure are?
Vision, blur,
Headache. What's the thing?
the disc, the papilledema.
Cupping of the optic disc, papilledema. Sorry, nothing said. Very good. Nausea, yeah, but mainly focus on papilledema and headaches. If you see those is most likely someone with high intracranial pressure. Or hemorrhage, because the venous sinuses are thrombosing. And you basically have to go and delete the clot. How do you delete the clot? Anti-clot agents. You don't need to know this for now. And then you could do surgery. The management isn't important for step 1 either. I never saw a single UWorld, whether exam question, whether anything. I saw this in first aid. I was like, I'll include it for the sake of completion. Okay, the ventricular system. So, we talked about blood. Now we need to talk about another fluid in the brain. CSF, very good. What is CSF? What's the function of it?
Lubrication, nutrients,
Shock,
blood doesn't care.
Yeah, so nutrients, and it's there for mechanical supports. It has a lot of functions. So yeah, intracranial pressure is very important. And CSF is very important. So CSF is produced, and it enters the lateral ventricles. Lateral ventricles, it will go through the intraventricular foramina for row into the third ventricle, which will go through the aqueduct sylvius into the fourth ventricle, which will go into the spinal cord or to whatever other channel, and it will come back and get absorbed through the arachnoid granulations. right? That's the process. Now, my question to you: what do you think I'm going to ask now?
What happens if it's
Hydrocephalus.
Yeah.
Yeah. So what could go wrong? Hydrocephalus is an example. It's one of the most important examples. It could be communicating or not communicating. What does that mean?
So the cerebrospinal fluid can still flow throughout the ventricular system because it's not blocked outside. This is what we call communicating.
Very good.
Non-communicating is when there's a block in the ventricular system itself rather than the
Absolutely. So let's recap on what she said. So Menek said that we have two types of hydrocephalus. Communicating, meaning it can pass through, and non-communicating, meaning there's a physical obstruction. So in communicating, on imaging, what do you guys expect that we'll see? If there's no issue specifically with them going through any of the canals, just there's impaired arachnoid granulation absorption, which is at the top of the brain. What do you think will happen?
Swelling
There will be swelling, of course, but of what?
of the brain. No,
The ventricle before the
Which ventricles?
the one before the obstruction. So like
No, and not in communicating, I mean.
communicate.
all of them.
All of them, yes. All of the ventricles will expand because they all cannot get the fluid to pass through normally. Like in non-communicating,
whatever's before.
exactly. So whatever's before it. So for example, if the aqueduct facilities is blocked, what will expand? Third ventricle. Because aqueduct facilities right here. So third ventricle will expand. And this will be non-communicating hydrocephalus due to an obstruction of the aqueduct facilities. Like, so we have. Do you guys know an infective cause of hydrocephalus? Meningitis, absolutely. Why? What kind of hydrocephalus does it cause? And why does it cause the hydrocephalus?
Communicating because the meninges inflamed.
Exactly. And what do the meninges cover? The brain, but specifically, sorry? What's Victoria? You said it. You were saying it. It's the right answer. It's the right answer. Say it.
I was
أنت تستطيع. Someone said. I heard it from them.
Yeah, subarachnoid.
Not subarachnoid, the arachnoid granulation.
Yes, that's
So the meninges cover the arachnoid granulation. If you inflame the meninges, you inflame the arachnoid granulations. If you inflame something, it swells, it gets blocked. So the CSF can't pass through. As a result, there's communicating hydrocephalus. And that's why we give steroids this is any clinical, but you give steroids in patients with suspected bacterial meningitis because you want to decrease the swelling and all the CSF to pass through.
Doctor, I don't understand the difference between communicating.
Okay, now I will draw it out. I guess you don't get your iPad out. Like now, okay. So we have the lateral ventricle. No one saw that. So we have lateral ventricle 1, lateral ventricle 2, whatever channel, third ventricle aqueduct, fourth ventricle, and then it goes like this. Okay, so CSF passes here, and it goes through here, and it goes through here, all the way back into these two, right? Which is covered by the arachnoid granulation. Okay, so the idea with hydrocephalus is it can be communicating or non-communicating. Non-communicating means there's a specific obstruction in either here, 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 or here. When there's an obstruction in one of these areas, the area behind it will swell. So if there's an obstruction right here, this area will swell. And if there's one here, this area will swell. Now, if it's communicating, that's non-communicating. In communicating, what happens? This cannot absorb. So as a result, all of these will get bigger. Does that answer your question?
Yes.
Does everyone get a better idea of it now? Jenna, go ahead.
So if one of the the ventricles gets blocked, is it only the one before it, or the one before it and everything else?
Mainly the ones behind it can as well, but it's mainly the one before it. So it's very severe. Go ahead.
What if it's the third ventricle? What would get it not? If the third ventricle is obstructed.
So if the third ventricle is obstructed, you mean okay? The obstruction happens in the channel,
Not in the
Not in the
ventricles themselves.
theoretically it could happen in the ventricles, but it would just be the lateral ventricles that expand as well. Does that answer your question? Great. Okay, everyone understands hydrocephalus?
Yes.
I think that like saves me some slides. Have you guys heard of this thing, spinal tap, lumbar puncture?
Yeah.
Okay, I am not going to cover all this. These are the layers you need to know exist that you're piercing. I mentioned. Let me see. Yeah, you do a lumbar puncture. When do you not do a lumbar puncture? Do you guys know?
Increasing.
Yeah.
Very good. And then there's like stuff about like CT versus no CT before doing it. Do you guys need to know that?
We just took it today.
We took a PBL like with contrast or without contrast.
And we took it today in neurology.
Yeah,
we did
just
figure
just a side note, most stuff in the brain doesn't need contrast because it masks the blood. Usually when they do it without contrast, it's because they want to see if there's blood versus something else or blood versus no blood, and then if you put contrast, whatever is there will look like blood. So it's just a very random fact, but I guess it might save you some time down the line. This is a table. If it's coming on your midterm, great. This table will help you in step 1. This will help you in your midterm on what kind of cells you'll see based on the inflammation. And then some other things. So subarachnoid hemorrhage has something called xanthochromia, yellowish discoloration of the CSF. And HSV encephalitis, so herpes simplex encephalitis, can cause bleeding. Hemorrhagic lymphopoetocytosis, random words. Okay, hydrocephalus, we pretty much talked about this. The only different thing we didn't say is you treat by shunting. Full card. Anyways, so that's our second objective. So let's break down this question. Honestly, these are long questions, so I'm going to read them. And okay, so a 99-year-old woman presents in the emergency department with right upper limb weakness, difficulty speaking, comprehending, and ataxia. She is previously healthy, no personal family history of whatever, a bunch of stuff. And which of the following arteries is most likely affected?
Left middle,
So raise your hands. All right, Lama, go ahead.
left middle cerebral artery
Why?
because it affects the middle, the wait.
I'm not saying you're wrong. I just want you to explain your answer.
I just know it's associated.
Yeah, pretty much. So if it's MCA, they will have upper limb weakness.
Okay.
Difficulty speaking. Why?
Because the broken
Broca is very good. And then ataxia can happen. So yeah, very good. Next question. Who's going to answer this? I'll read it out. And I want Jenna, you'll answer it, but I'll read it out first. 21-year-old male presents the emergency department after getting stabbed by his ex-girlfriend. He is vitally unstable and showing signs of hemorrhagic shock. Which of the following structures is most likely to be affected first?
So ones that are watershed.
So watershed areas aren't here. What were the other structures? Sorry?
Hippocampus.
Very good. Hippocampus. Very good. Does anyone remember any other structures that?
The thalamus,
Hypothalamus.
internal capsule,
Basal
basal
ganglia.
ganglia.
A lot of words, but you're all correct. And then cerebellum, of course. Don't forget the cerebellum homunculus, by the way, is my favorite homunculus, as a side note. It's much cuter. I'll show you guys a picture of
There's
that.
another one.
There's a cerebellar homunculus.
Does
No.
it
The
have
cerebellum
cerebellum
lecture, but that wasn't mentioned.
Sorry?
We took the cerebellum lecture, but the
Is it?
homunculus wasn't
Oh, it's not on my crash course either, but I'll show it to you guys at the end.
Yep.
It's a very cute homunculus. So, my personal opinion, my favorite homunculus. There's two options, but that one's my favorite. Okay. Based on the following visual field test, the patient has the lesion of which of the following arteries? Who wants to help me out? Medic, you look like you want to help me out.
There's
Oh.
macular sparing.
Yeah. Say it. Sorry? Say it with confidence. Say it with pride.
PCA.
PCA. Very good. Play it. And what is this visual field defect called? Everyone together.
contralateral homonomous.
Homonymous anosmia.
You guys know that one meme of like the choir in Diary of a Wimpy Kid? In like the Diary of a Wimpy Kid movie, the one meme of like the choir?
No.
Oh, man.
هدف اليسار صح؟
Huh?
هدف اليسار صح؟ ولا في اليمين؟
What do you think?
There is a contralateral أظن بيكون في اليسار.
What do you guys think? He's asking, is this left or right?
Left.
You're correct. It is left.
I'm so confused. What does this image mean? Like, is that
So
a line?
the black is what they can't see.
Huh?
The black is what they can't see.
You can't.
So the left.
But there's a black dot on the white.
Yeah. What's that?
Artifact.
Oh, what?
Okay, one thing in imaging. By the way, when you guys become doctors, inshallah, when I become a doctor too, I'll see this a lot. But ahyanan, when you're doing imaging, you'll find something called an artifact. This is something that looks like it exists, but it doesn't. So if I were to repeat this test, this would
It's
go
right
away.
here.
Oh, sorry?
I felt like it doesn't exist to me. I'm like,
No, it just doesn't exist, period. And it's there as a mistake from the imaging, from the technology, whatever.
It's called an artifact.
Okay, a 103-year-old man
does it even exist?
was involved in an MVA, motor vehicle accident, and is brought to the emergency department. He has waxing and waning consciousness. Forensic inspection of the accident reveals urine in the driver's seat, which is the patient, and it's dated to be older by seconds compared to the confirmed time of the crash. Autopsy reveals atrophy of the brain. Which of the following arteries is most likely affected?
The eye.
So I need someone to raise their hand. Someone that didn't answer yet. Well, I want to give everyone the chance because when you say it, you understand. I will force someone to answer. I'm looking at you, bro. I want you to try this question out. Okay. What do you think is the key giveaway in this question?
Urinary incontinence.
Urinary incontinence.
بس كانت we just say he was in a motor vehicle accident ممكن من الخوف before.
Seconds before.
Let's just.
You could assume all of this is because he's 103 years old. Right?
You're right. He may not have had a stroke. Let's assume I'm talking about a stroke. So I'm saying he had a stroke, and as a result of the stroke, he had urinary incontinence. والله صح عليكم. If you think about it, it's not really the best question. Sorry? A, why?
There's something involved.
Yeah.
Anterior cerebral artery.
Absolutely. Because it controls the parietal lobe. The specific part that controls the urinary bladder, genitals, is controlled by the ACA. Very good. Next question. 20. All right, you'll be able to answer, but you don't.
Can you re-explain the distal and proximal and ACA?
Yeah, I have a similar question. What case would we have that would make the answer proximal?
There would not be a case. But let's explain. Okay, so I'm going to draw you guys a circle with this. So we have the internal carotid, which is the MCA. We have another one, and we have this over here, and this over here, and we have this over here. This is communicating, and this is PCA. This is communicating. Okay, great. So this is ACA. This is ACA. This is ACOM A. This is ICA, which becomes MCA. This is PCO and A. My handwriting is amazing, by the way.
Yeah, we can understand.
It looks like NCA, but it's PCA. Okay, great. So right over here, this is the anterior communicating artery, right? And we said that if you have a stroke, and we're asking, is it proximal or distal? It's most likely to be distal. The reason is the blood flows this way. So if the blood is flowing here, and let's say this is obstructed, the blood will come this way because of the pressure. So it'll meet halfway. So this won't really cause the stroke, most likely. But if this is obstructed, there's nothing to connect. Do you guys understand that point?
Wait, that confused me.
Okay, let's recap.
Can you use a darker pen?
Is there
not.
there is a dark. That's cringe. Voting stickers.
There's
Okay. Try dark black. Okay. So, let's just try to bring this over here. So we have okay. Do you guys see this structure over here?
yes.
Okay. This artery that's coming here is the internal carotid. The internal carotid is going to give the ACA, the MCA, and the posterior communicating, which is going to give out the PCA. All right. And then here, this is the anterior communicating artery. Okay. So, if we say distal to the anterior communicating artery, we mean here. If we say proximal, we mean here. All right. So that's the first thing that we need to understand. The second thing is when the blood here is flowing upwards, let's say, or anterior. So it's going this way towards these arteries. But the blood here is going this way towards those arteries. So let's just forget about that for now. All right, let's focus on this right here. The idea is, for example, if the blood is blocked here, like in the anterior communicating artery, proximal to the anterior communicating artery, like sorry, did I say anterior communicating twice? My bad. If the anterior cerebral is blocked proximal to the anterior communicating, and before it, blood will come here. Blood will also come here. Why? Because the blood is flowing like this, into this, into this. So it's mixing. It's an anastomosis. The idea is the blood will go here if it needs to. Because there's going to be a pressure difference. If blood isn't coming from here, by any physics, the blood will, by default, go here to supply this area. So it won't, most likely, will not produce a stroke. Yeah, of course, it could. There's never say never. Let's say it could. Most likely not produce a stroke. However, here, there is no connection. If I block here, or here, or here, there is no connection after this point. Khalas, it's just going to be obstructed and will definitely cause a stroke. Is everyone clear?
Yes.
I know it can be confusing. I was confused too. Well, honestly, look, for the sake of your midterm, this won't come. But I hope, inshallah, you get a UWorld question or several UWorld questions about this, or you remember me.
The concept isn't like, oh, if the distal one's connected, then something might happen. The concept is that there's anastomosis.
There's anastomosis, so it'll come through. Exactly. Proximal will be supported by anastomosis. Distal is not. Does that make sense?
Yes.
Everyone clear?
Yes.
All right. I see several people nodding their heads. That makes me happy. Yeah. Okay. So, Victoria, you're gonna help me with this question. Okay, 24-year-old female presents in the emergency department complaining of neck pain and headache for 1 week. She's vitally stable except for a fever at 40 degrees. She has no sick contact, health condition, headache is not resolved by painkillers. She is brought by her older sister that lives with her, who mentioned that she has recently been acting weird for the last few weeks. Physical exam reveals papilledema. Which of the following is the best next step? So your answer is lumbar puncture. Why? So you do, okay, the reason we do a lumbar puncture in patients with, so what do you think she has?
Meningitis.
Victoria, what do you think she has? I'd say it. Meningitis. Okay. Meningitis is an infection of the brain. So we do a lumbar puncture and we see what exactly is infecting the brain. صح? Well, but before we do a lumbar puncture, we need to do something. Wait, I want her to answer.
Give antibiotics.
You think it's giving antibiotics? Victoria, what do you think? Okay, so she has papilledema. What does this mean? High intracranial pressure. So we need to make sure this is not one-sided. That's going to cause the brain to herniate. So what will we do? CT. For your guys' sake, I remember for us, they emphasized CT before lumbar puncture. This was something emphasized for us at our time. But I made sure it was precise to the scenario. Why would we not give antibiotics before lumbar puncture? When we're doing the lumbar puncture, we're going to take it to culture. If we already killed the bacteria, we won't know what's infecting it. This, I understand, but I appreciate your support, your will to treat the patient quickly. I hope, and inshallah, if this ever happens to you and the patient is fully cured. Yeah. Okay, next one. So this is weird, but I want you, Annie, forget this case. Look at the image.
Can you zoom in on it?
I can zoom in on it.
Maybe like touch the screen and then do this.
I think it's touch.
It's such. Let's see. Yeah. Okay.
Both your hands
Both
like
hands.
this.
Yeah, try both of your hands.
No,
Like
both
this.
your hands. Okay, never mind.
Yeah, this is.
Or we can
Okay, I
always
see something. Now
We're back.
Yeah.
Okay. Forget this. Okay. Let's assume. So this is what hydrocephalus, right?
Yes.
Let's assume, and this is the only one that's large. Is this communicating or not communicating?
not
So what's an obstruction of, or what venture? What's obstructed? What structure is obstructed?
Ventricle is enlarged
Yeah.
because of the Monroe. Duct.
Yeah. So it's an obstruction after the third ventricle. Very good.
Yeah.
And if they were all enlarged,
I mean,
very good. And if this was due to an infection,
also meningitis.
meningitis. Great. We are done with 2 objectives. So what's the time now?
4.
Wow, we actually went faster than I thought. Like, أنا صراحة, I want to give us a small break عشان we put in a lot of information, صح?
Yeah.
خلينا we take 5 minutes, we'll come back 4:13. طيب, don't go too far.
Okay.
And if you have any questions, I'll answer them now.
excuse me, Doctor, can you explain the picture again?
Which picture? The imaging?
Yes.
Okay, come here. Okay. So you see this picture over here, right? Third ventricle. Okay. The third ventricle was much larger than the other ventricles, correct? It was much larger than the normal.
Isn't this the aqueduct of cervix?
Yes, this is Sylvian aqueduct right there. This is the interventricular foramen of the brain, Sylvian aqueduct. So if the third ventricle is the only one that's large, this means what's obstructed? After this is the nose. As a result, the third ventricle will be the one section. Let's say this is considered large. Let's say the fourth ventricle is not shown, but let's say that's large. What would be the cause?
You know what? Like, you wanna leave me?
So third ventricle here is
What I was thinking was, I thought third ventricle was
You only
no. This is the lateral ventricles. This is the third ventricle. Now there's the fourth ventricle right here, next to the cerebellum.
She says do not remove except when we're
Sorry, this is in front of the cerebellum. Correct.
I think we need to.
Let me try to see if I have
We don't need to.
just to show you. Let's see.
That's
Yeah. So. Yeah. So this is the lateral ventricle. Yeah, right here. Okay.
yes.
Are the lateral ventricles right behind?
Area of
Yes, exactly. Sorry, it was right here. Third ventricle. This is the lateral ventricle. These two pink ones are the lateral ventricle. Let's see.
oh my god.
Take my time.
I'm sorry, I
No,
just
no.
don't understand.
No, it's fine. Giga. No, you're right. This is the fourth ventricle.
Okay.
Yeah, so this would be an obstruction of everything under it.
Okay.
Yeah, you're absolutely correct. But the idea is, understand, it's non-communicative hydrocephalus. Thank you for pointing it out.
It's okay. Thank you so much.
Don't you have endometral?
No, you're doing Neuro. We just finished, guys. Literally just finished. We just finished. I meant GIT, what is it?
Yeah, man. How are you? How's everything? What will you have? Sorry? Sorry, I didn't hear you. Oh, no. طيب. لا ما شاء الله طيب. هو شكلك في رمضان عشان رمضان لا هو الصراحة I was painful my face went my face fat went decrease. And I wanted to decrease just a little. I don't want to decrease. I just want to not have a massive increase after.
Rafi, did you like Neuro?
I love Neuro. It was very fun.
You seem like the kind of
Sorry.
you seem like the kind of person who like
It was a very fun block.
it is super fun. It's the greatest block that's ever existed. I don't want to take anything else.
I don't
I think
blame
I'm
you.
good.
I don't blame you.
I think I need to graduate now.
What specialty do you
I like cardiology the most.
Oh.
say? Me
Third year CVP is amazing.
yes, same. I mean, I like CPR in first year.
You'll like it again in third year. Third year is way better. Once you see like CVP clinically, it's very fun. Got your house literally right there. Still won't get you. That's fine. No, I just want feedback. Honestly, the only reason I want you to answer is just because you remember it when you say what you think. And if you get it wrong, I have more questions. I guess let's start. I don't know if you guys need to set anything up, but I guess we'll start. Anything else? I don't know if you need to set anything up. We can start now. Right. Oh yeah. Just check if the mic is working.
Let's start the meeting.
You're all good. How did you? Oh yeah, sure. Basically here. There. All right. All right. Okay, guys, we're gonna start now. Okay. So this slide right here is just to explain some of the words we already talked about. And right now, we finished with the basic anatomy. We talked about the fluid anatomy. Now it's time to talk about diseases. So starting off with aphasia. When did we talk about aphasia?
Broncos.
And what does it mean?
Can't speak.
Can't speak. Very good. So there's a difference between not being able to speak and not being able to use language. So not being able to speak, this is a muscular issue. This is called dysarthria. But if you can't use the language, for example, if you cannot initiate speech, this is aphasia. So the key word is language versus speech. Agraphia sounds like inability to do graphs, but really it just means you can't write spontaneously. Astereognosis, what's that?
Can't recognize my shape.
By
Touch shape by
shape and size. So you touch something, you can't recognize shape by size. Apraxia,
or
you can read, it's fine by the way.
like playing a piano.
Playing piano. Or what else? Tying your shoes or riding a bike. What? Brushing your Exactly. So agnosia is inability to recognize something that you see. And anosmia.
Can't smell.
Very good. So the idea here is there's a page in first aid, which is everything that could go wrong in a nutshell. So these are the ones you need to study. These are ones that are not part of my lecture, so I just included them because I'm very kind and I'm very amazed. But anyways, we'll talk about them. Frontal lobe. If you have damage of the prefrontal cortex, this can cause an altered mood or its inhibition. Frontal eye fields. So the eyes will look towards the side of the lesion. And if you guys go back all the way to the frontal lobe slide, the YouTube video is an explanation of it. Because I could explain it to you, but you guys won't understand it until you see it.
Can we see it?
Sure.
Yeah.
Frontal eye field lesions. Lesions in the frontal eye field result in loss of conjugate movement of the eyeballs. The eyes are deviated to the side of the lesion, with inability to turn to the opposite side. The involuntary tracking movement of the eyes while looking at moving objects remains unaffected.
Yep. So the way I like to think of this lesion, when I want to remember what it looks like, I just think of any side eye. Okay. So that works for me. Whatever works for you works for you. Okay. Okay, great. So frontal eye fields, basal ganglia. It's part of the frontal lobe. It can cause tremor. And tremor, what diseases do you think have tremors? Parkinson's and Huntington's. Very good. I don't care if you guys read, by the way. It's there for you to read.
I'm trying to scavenge my brain. Sorry.
It's okay. I get it. I was a second year once too. The subthalamic nucleus will cause contralateral hemibilismus. Hemibilismus is just flailing movements. It's literally like this. Like that's it. The parietal lobe, we said it could be Gerstmann versus hemi-neglect, and we have slides on those. Temporal, we have the amygdala. Did you guys start psych?
No.
Okay, so you two attended my psych lectures back in AVP.
Yes.
And so I talked about the general anatomy of the psychiatric system. I talked about the amygdala. And basically, this is important in a lot of psychiatric diseases, anxiety, depression, mood, whatever. But essentially, there's a story about a guy, Finch, I believe. What happened was he got like speared in the brain. Yeah, yes.
What's it called? What's his name?
I think it was Finch.
No, his first name was some. It's like he said
Phineas. Phineas Gage. Yes,
Yeah.
it was Phineas Gage. So he got speared in the head, and it affected his amygdala, and his personality changed forever. Now, is it called Phineas Gage syndrome? No, it's called Clifford Boosie. I don't know what this guy is. Well, he took credit for a guy that got. Yeah, and the crazy thing is, Phineas Gage was alive. Now they're probably both dead, but
Is that how they started lobotomies?
it could be.
Maybe.
No, but Phineas Gage was a guy. That's not how. they were sexist back then. Not anymore. Now lobotomies are for everyone.
Nice.
Then we have the hippocampus. The hippocampus. What did we say about it earlier?
It's a water.
It's not a watershed area, but it's affected in states of hyperfusion. So absolutely. But if there's a lesion of it, it causes anterograde amnesia. Occipital. Yeah, let's say the word.
Eyeballs.
Very good. All right, great. And then the brainstem, you have the mammillary bodies. If you have a lesion of this, like an alcoholic, it's called Wernicke-Korsakoff. Reticular formation will affect consciousness. The dorsal midbrain will cause something called perinod. The medial longitudinal, this is what you were talking about. The medial longitudinal fasciculus causes intranuclear ophthalmoplegia. So it's impaired adduction. Where do you have impaired abduction? Abducens nerve. Very good. The abducens nerve. Which is cranial nerve what? 6. Very good. And it's in what parts of the brainstem? Is it in the medial or lateral pons? So what artery would affect it in a stroke? Basilar. Very good. Basilar artery. Okay.
I was going to say Ica.
Good guess. Ica is what? No, I know the name, but what does it affect? Lateral pons. Very good. And then cerebellum. If you affect the vermis, causes truncal ataxia, hemisphere, intense tremor. Not my issue, someone else's. So great. Let's talk about Drisman versus heavy neglect. So Drisman is basically a patient who cannot do basic math, writes spontaneously, and puts his left shoe on his right foot. So they have a tetrad of agraphia. Agraphia is what? Right spontaneously. Very good. Acalculia. Can't do basic math, like all of us, which is why we're here. Agnosia. Can't recognize.
Yeah.
So finger agnosia, so they can't recognize the fingers. And then left-right disorientation. So left shoe, right foot. And then we said, is this dominant or non-dominant?
Dominant.
So in most people, this would be what lobe?
Left.
Left parietal lobe. Very good, guys. Right? Heavy neglect.
Right.
So they ignore the entire side. So if it happens for the most part in the right lobe, what side is most likely to be neglected? Left, because it's contralateral. Very good. So yeah, one of the tests they do is they ask them to draw a clock. And this is a sign that they do not know what a clock is. They know what a clock is, they just don't know the math. Hey, look, so honestly speaking, I think at some point in our life, when we were in elementary school, we all drew a clock like this.
Yeah.
Doesn't mean we're having neglect, it just means we were developing. Okay, great. Aphasia. So this table right here, ignore transcortical, whatever. I don't care about that. Focus on this, right here. So, Broca's aphasia, Broca can't talk, so they cannot produce fluent speech, but they understand. Wernicke, what? So, they can speak fluently, but they don't understand. And they don't realize that what they're saying is not fluent. Sorry? Word salad, very good. Wernicke salad. And then conductive, basically, they understand, and they can comprehend, but they can't repeat.
Wait, I have a question. For Wernicke's, do they know that they're speaking?
No. They're unaware. So it's not receptive, it's non-receptive agents. There's other words for it. I don't like receptive, non-receptive. Sorry? So they can speak, they can make words that make sense. But they don't, they say words, but they don't say them in the right sequence.
It's not really about them. I don't know if they can tell that they're speaking.
They can't tell. They don't realize that you don't understand them.
Because they can't conduct it.
Exactly, bro, because they realize that what they're saying is gibberish.
They're frustrated.
They're very frustrated. There wasn't a Dr. House. There was no Dr. House episode, was it?
There was. It was a symptom. It wasn't like.
What season was this?
I'm pretty sure I
No
will.
life. Go study.
No, because I watched it.
That was a trap. Okay, Wernicke Korsakoff. This happens in alcoholics. One of the reasons why alcoholics happen. Great. Anyways, so the idea is thiamine is what? What's thiamine? B1. It's a vitamin.
Yeah.
Right? And if there's a deficiency of thiamine, this causes Wernicke Korsakoff. Wernicke is the first thing. It's acute, somewhat reversible, damage to the mammillary bodies. Korsakoff is chronic. So chronic cough or chronic, for example, cough syndrome. So chronic, and then Wernicke's is acute. So yeah, encephalopathy, ophthalmoplegia, gait ataxia, versus memory loss, confabulation, and altered personality. So they're gonna, for example, an alcoholic, what happens? They walk funny, they have a sailor's gait. They can have, they'll be a little bit disoriented. But when they start making stuff up, and when they start forgetting things, or their personality changes, this is Korsakoff. The treatment is thiamine, then glucose, because they also have a glucose deficiency in patients. Perineal syndrome. So this is usually a pinealoma is a tumor of the pineal gland. Do you guys know what the pineal gland produces? Melatonin, very good. So it controls the circadian rhythm. But essentially, it can happen as a tumor. And when it compresses the dorsal midbrain, it presents as upward gait palsy, so they can't look up. They have convergence, retraction, nystagmus, big word, forget about it. And then pupillary hyperreflexia. So you'll think it's definitely something wrong in the midbrain, but the second they say upward gaze palsy and they can't look up, think paranoid. Will this come on your MCQs? No. But this is a USMLE question, so I have to include everything. And Salaha, I included this because I didn't know this until 2 weeks before my exam. Okay, now that's the NPC stuff. Now we go into the real stuff, strokes. So, stroke, what is a stroke? Occlusion of the sudden onset, occlusion of a blood vessel in the brain. It causes weakness, causes whatever. So, someone's going to come to you with a weakness or a headache. You do a non-contrast CT, and then you decide do you give them TPA or not. And you guys know who we give TPA to versus tissue plasminogen activator. It breaks the clots. So do you know what kind of patients we give that to or not?
Emergency patients. If you can save them, look within the window.
Okay, that's fine. I'll cover it later.
It's a window of time.
There's a window of time, but there's nothing that's more important than the window of time, which is the
Because
type.
they're more susceptible to bleeding.
Not exactly. Okay, we'll get into it later.
Oh, there was never mind.
It's the PBL, yeah.
Yeah, we took it.
All right. But remember, ischemic can take TPA most of the time. Hemorrhagic, no. Anyways, as an exam question, they will give you a patient with weakness, complaining of weakness. And they may ask you, where is the weakness? So you need to see, is this unilateral versus bilateral? Is this motor or sensory? Where is the weakness? What essentially is the patient complaining of? And localized. So if I told you guys, this is someone with left homonymous hemianopsia with macular sparing,
Right, PCA.
right PCA. So right occipital stroke, for example. That's the idea, localized. The next best step, if you suspect a stroke, is alert the stroke team or do a non-contrast CT. Yeah. And you need to treat it quickly. There's an MI team, there's a stroke code, MI code.
Time is money.
Time is money, exactly. And these patients.
Is life. Time is money.
So yeah, you want to do a non-conscious CT, and sometimes they may ask you to identify images. And then based on the symptoms, how to manage. So, do you give this patient TPA or not? This is a non-contrast CT. And the reason I included this is to show you guys the territories of the blood vessels. So, we're going to talk about ischemic strokes. Ischemic strokes means there's ischemia. Simple as that, صح? Ischemia becomes an infarction. Infarction becomes liquefactive necrosis. So, the idea is the vessel is completely occluded, and the symptoms don't reverse on their own. This is important to differentiate from something else. The idea is, on the CT, they'll usually show up as a territorial infarct. So, this is most of the time due to thrombosis, such as atherosclerosis. It can happen as an embolus due to infective endocarditis or atrial fibrillation. It can happen as hypoxia and heart surgery. What areas are the first in the brain to be affected in hypoxia? What? Did I say watershed too much?
No, because it's the first time I learned this word. So I'm excited.
I get that feeling. All right. No, don't be sorry. That's great. All right. So after ruling out a hemorrhagic stroke, see if they're a candidate for a tissue plasminogen activator. If they are, great, give it to them. Oh, talk it out. If it's TIA, basically the idea here is that there's a temporary occlusion that goes away after 30 minutes without causing an infarction. So when you do an MRI, when you do a CT, you're not going to see anything because nothing happened. It's just a small blockage. Well, nothing happened.
Because what's what they call the mini stroke?
Mini stroke. Yeah, exactly. Baby stroke. Very good. And we have something called amaurosis fugax. All right. Your homework is to look up what this word means.
This is the eye thing where they go blind for a little.
Okay, you don't need to look it up anymore. I'm not blind. So they go temporarily blind, and this is called amaurosis fugax. I thought it was a fungal infection when I first saw it, but no, it turns out it means blindness. So yeah, ischemic strokes. You do a CT, and then if you know it's not hemorrhagic, what do you give them? TPA, alteplase, tissue plasminogen activator, whatever. TIA, you don't need to do anything. خلاص. You just need to counsel them on risk factors, make sure that if they're a smoker, stop smoking, decrease atherosclerosis risk factors. Go ahead.
So when in the beginning you were like, who do you give TPA versus who do you not? The answer.
This is the guy you give TPA. So if this guy comes to you and you see, for example, this area is all ischemic, and I have pictures, by the way, to show you what ischemia looks like. This area is all ischemic, and he's actively complaining of a stroke, and you're within the right time window, which isn't important for now, you give him TPA. As long as there's no contraindications. There are contraindications. I don't think they're important for you guys. They're more important to any later on. Let's say any increased risk of bleeding is a relative or absolute contraindication. Because if they bleed, they'll have a hemorrhagic stroke instead. You fix one problem, cause another.
Excuse me, doctor, I'm sorry. Can you please repeat TIA?
TIA is transient ischemic attack. As the doctor said, baby stroke. The idea here is that there is an occlusion, but it's temporary. It goes away on its own, and the symptoms reverse. So the patient is completely normal. When you do an imaging, a CT or an MRI, you won't see anything because there's no infarction. And it can also cause amaurosis fugax. This is basically just temporary blindness. Everyone understands?
Yep.
Great. So you can localize, and this you already know.
Yeah.
This is all stuff you already know. And I mentioned earlier that they can become incontinent, and they can have anosmia, and they can have vision loss and Gershman. And then these guys they can have visual agnosia. They can't recognize people, but less common. Okay, so over here, this is an internal carotid artery stroke. Why? Everything is dark. So this dark area in a non-contrast CT means there's ischemia. So it means the tissue is dead or dying. So the idea here is all the territories are affected, so therefore it's most likely internal carotid. But over here, for example, not all the territories. The front is still fine, the back is still fine. So this is an MCA. An MCA, like I said, supplies most of the brain. The ACA, this is not a clear image, but let's assume you saw some darkness in the front.
That's everything.
That looks like this is a bad image, honestly.
That's a very thick skull.
Yeah.
Yeah, no, they most likely took this from.
A baby.
No, not. Why is a baby complaining?
I don't know, big head.
Okay, you know what? I'm giving you have a homework. If a baby has a stroke, what are causes? It's my homework. So, anyways, and then over here in the back, if you have a stroke in the occipital lobe, this is most likely PCA. And like we said, the darkest is ischemia. Okay, histopathologic changes. I am not going to sit here and explain to you and read words. This is for memorization. I don't know if you need to memorize it. It's not too important for steps. Just remember, after 24 hours, you'll have red neurons.
This is for our midterm. It's in 4 days. Let's talk about
So
it.
nothing happens after. So when you do a histopathologic analysis, after 0 to 12 hours, nothing will happen. From 12 to 24 hours, you might see eosinophilic cytoplasm and something called red neurons. So the neurons literally look red. 24/72, you'll see neutrophils. So 3 days of neutrophils. After neutrophils, normally in any other part of the body, you'd have what? If macrophages. But in the brain, we have microglia. So for 3 to 5 days, you'll have microglia. And in 1 to 2 weeks, you'll have reactive gliosis and neovascularization. So this is the formation of the scar and new blood vessels. Because, sorry?
By astrocytes.
Yeah.
By I thought you were asking why astrocytes. I didn't hear you say by astrocytes. No, you're correct. And then 2 to 8 weeks of glial scar solidifies. Great, understood?
Yes.
Inflammation, the only thing that's different is microglia, reactive gliosis, red neurons. Great? Are you sure?
Yes.
Good. Okay, hemorrhagic strokes are a little bit more complicated because instead of talking about territory, we talk about the type of stroke itself. So starting off with epidural. The most common cause for hemorrhagic strokes is trauma. If someone gets a baseball bat and hits you on the head, you're probably gonna have a stroke. If you're still alive. Anyways, epidural. The idea here is you have something called the middle meningeal arteries. If they rupture, this is most likely to cause an epidural hematoma or an epidural stroke. And the idea here is that the patients will have something called a lucid period. What is a lucid period?
Lucid
Hallucination.
Not exactly.
No, it's
You're not
aware.
awake.
They're
you're not,
no, they are awake. They're fully awake.
yeah,
So
you're not awake, but you're not like you're in between.
exactly. So they go unconscious after getting hit. They wake up, and then they go unconscious again. So the period where they're awake is called a lucid interval. Very important in terms of history of an epidural hematoma, and it shows up as a biconvex lesion. Now, I'm not going to ask you guys, oh, do you know what I mean by biconvex? Because no one's going to be able to explain it to me. Okay, medic might be able to explain it to me, but I won't be able to explain it to me. But we have pictures. Rather than subdural, again, trauma, and instead of the middle meningeal artery, it's bridging veins. And instead of being a biconvex, it's banana.
I have a question. What's the most common cause of epidural hemorrhages? Not common cause, but it usually happens in alcoholics. What's it?
It can happen in alcoholics if they fall down and hit their head. But honestly, in terms of which patient population is the most at risk, whoever can encounter trauma, generally. Interesting point. Okay, great. Subarachnoid. There is a very common history, or a very typical history that examiners like you to know.
Very,
Sorry?
very.
Very aneurysm, but in terms of the patient presenting, they will tell you, I have the worst headache of my life. Now, I know we say that on a daily basis. Inshallah, none of us have a subarachnoid hemorrhage because most people die from it. But assuming the patient were to come to the hospital and say that they have the worst headache of their life, they might tell the doctor that they have an aneurysm, for example. They may know of an aneurysm. They may know that they have a kidney disease when they were a child, and that kidney disease is associated with aneurysms, polycystic kidney disease. And they can have meningismus. What's meningismus? Meningismus.
Movement of the
No.
meninges.
Good guess. It has something to do with the meninges. It's not movement. It's symptoms. Okay, meningitis. What are the symptoms?
Headache.
High IC
Next.
High ICP, headache, stiff neck. Those symptoms are of meningitis. These symptoms themselves are called meningismus. So meningitis is not the only cause of meningismus, but it's just so typical that khalas.
Why would they name it just?
Yeah.
That's a good question. I don't know. I didn't do it. The glove didn't fit. Anyways, so meningismus can happen in subarachnoid hemorrhage. And subarachnoid hemorrhage, why? Why? Because it irritates the meninges, causes any meningeal irritation, which is going to cause meningismus. And like we said earlier, when you do a spinal tap, you have xanthochromia, which is discoloration of the CSF. You might see a hyperdense lesion around the circle of Willis. This is representative of the aneurysm. Sorry? Lemon, yeah, it could look like a lemon.
Isn't the lemon?
So, no, it's actually a clementine.
What?
You see my point? It doesn't make sense we're calling it fruits. I mean, call it whatever you want to call it. A ham-shaped biconvex, and then banana lesion.
Oh yeah, that is banana. Subdural was.
Subdural is banana.
Yeah. Wait.
It's a lemon, guys.
What are we calling it?
Subdural.
Guys, no lemons, please. Okay, then intraparenchymal. This is one that's not necessarily associated with trauma. Rather, it's associated with hypertension. And this is the rupture of a Charcot-Bouchard aneurysm. And this one I call a golf ball on CT. I named it a golf ball. It's probably not a golf ball, but I remember it as golf ball lesion on CT because this tends to happen in older patients like amyloid angiopathy. And so old people like to play golf.
Can I write golf ball lesion on the exam?
Well, look, if it was my exam, I would have no problem, but it's not. Besides, you write it anyway, see what happens. Social experiments. If you pass the exam, great, you continue. If not,
We're just testing out.
you did it for the mind. Anyways, so these are lesions over here. Ignore the right image, focus on the left image. So over here, this is biconvex, typical of. So historically, what would this patient have? What did I say was important in the history? Trauma.
Oh, no, waking up and then.
Yes.
Yeah, lucid.
Lucid. Very good. And then over here we have banana.
Yeah.
No, right here we have banana. So
Epidural. Subdural.
subdural. Great. Subdural. They're just gonna be asleep.
That does not look like a banana.
I think the second.
Okay,
It's not
yeah,
right.
it does.
It's a little too right actually. It's
Yeah.
almost expired. Anyways,
Third ventricle is enlarged. Does this mean that this causes? Is it just the rest or is it?
sorry.
is it
There's the third ventricle doesn't show here.
Wait.
You mean-
Oh, sorry.
Oh, are you talking about this shift right
I
here?
meant
This
the
is,
lateral ventricle.
so this is a very interesting point. So the thing is with hematomas, why are they very bad? Why are they emergencies? Because they actually shift the brain matter. And this can cause nerve lesions, this can cause herniation, it causes a lot of syndromes. So that's a very excellent point that you pointed out. Thank you, Manek.
Is this-
هذا الب-
Where's the brain?
فوق على اليمين.
ليش كان
Wait,
اسود؟
what happened to that?
And الأسود, this is CSF.
I have a question.
Go ahead.
In the first images, there's no brain.
I feel like they're
No, these are just one. These are side by side images. So this is showing you that there's a skull fracture. So and again, they can like edit the software to show you X and Y is happening. This is showing you a skull fracture over here.
I thought he didn't have a brain and they're pointing at something very.
Me too.
They're like, look at this part. I know he doesn't have a brain.
This is us when we solve exams.
Yep.
All right. Right in here, for example, here you just have hyperintensities. You don't see much, but you have hyperintensities, and they want you to imagine that this is circle Willis. Honestly, this image is better in E instead of F. This is hyperintensity around the circle of Willis. Worst headache of your life.
Ooh,
Subarachnoid berry aneurysm rupture. They have kidney disease as kids. And then over here, you have a golf ball. A broken golf ball, mind you, but it's a golf ball. Right? So this is intraparenchymal. Could be due to what kind of aneurysm? Charcot-Bouchard. Could be hypertensive or amyloid angiopathy. Amyloid angiopathy if it's an old patient with this lesion. Okay. Now the thing is, we have cerebral strokes and we have non-cerebral strokes. So what do other strokes have that cerebral strokes don't have? Let's take brainstem strokes. Do you guys study rule of 4?
Yeah.
Okay, I love rule of 4. When I understood rule of 4, I felt like I was on top of the world. That's when I loved neuro. When I understood rule of 4. Okay, to this day, I still remember the good feeling I had when I learned rule of 4. Like, it felt better than getting done with someone. I'm just kidding. That was really good. But anyways, man. So the idea here with rule of 4 is essentially you will have the symptoms that correspond with rule of 4 without cortical signs. So you won't have blindness, for example. You won't have incontinence, like the 103-year-old in the car accident, who may or may not have it due to the stroke, mind you. And the idea here is they will have gaze palsy rather than a blindness lesion. And then, for example, here it's just comparing PCA versus upper brainstem. That's the same point I mentioned. In the midbrain, gaze palsy, and then PCA stroke affecting the cerebrum would be vision loss. Right then, lenticular striates, this is a thalamic stroke. Internal capsule thalamic strokes. The idea is, remember how with MCA versus AC, so MCA would affect only half of the upper body, or half of the body on one side. And then ACA would affect the lower limb of one side. The idea with lenticular striates is it affects the entire contralateral side. So it can be only motor or only sensory, and this can happen as intraparenchymal hemorrhage as well. So someone with, for example, a Charcot-Bouchard aneurysm or a golf ball lesion on a CT, they may have lenticular striate stroke. Funny enough. And it causes thalamic syndrome, thalamic symptoms, which is the entire side. Not just one part of an entire side, the entire side. And they don't have hemineglect or aphasia or loss of vision as we see in cerebral strokes.
So the second one is also non-cerebral.
Yeah, these are two non-cerebral examples, brainstem and lenticular striates. The idea is with brainstem, you'll look for rule of 4 and gaze palsies. With lenticular striates, you look for the entire side being affected.
What's the particular story?
And these are very small arteries which supply the thalamus, the internal capsule, all those structures. Okay, what about other words that have the word stroke or related to it? So, neonatal interventricular hemorrhage. So, do you guys know what the ventricles are?
Yeah.
Can you point to them on the board? Those. Yeah, the red image. So, in premature babies, because they have something called the germinal matrix, and when it's weak, blood can seep through, and this causes interventricular hemorrhage. It causes loss of consciousness, bulging fontanelle, hypertension, seizures, and it's associated with premature or low birth weight. Mena, go ahead. Okay, this is going to be a whole other discussion. But the idea is, it exists in babies, and it's part of the brain development. Just Aishan, we don't go into like stories of other things. But the idea you need to know is, in a premature or low birth weight baby, it's very weak and immature. It hasn't formed well yet. So as a result, it covers the ventricles. There will be bleeding into the ventricles. And then, in terms of when you think of a baby having a brain bleed, you should also think about vitamin K deficiency. And the typical scenario here would be a baby born at home. So the idea is they didn't get a vitamin K shot or an erythromycin ointment in the hospital. and they were born at home without doctor supervision, and they had a brain bleed. In terms of aneurysms, we talked about saccular aneurysm, berry aneurysm, which is seen where berry aneurysm, subarachnoid, subarachnoid, and then Charcot-Bouchard was intraparenchymal. Very good. Yeah. So like I said, it's associated with kidney disease. Kidney disease is a very important association for saccular, and it affects the anterior communicating artery. So that's where the aneurysm will be, and as a result, that causes blindness and ACA stroke. Go ahead.
Jenna asked what's the berry.
I didn't hear you. Sorry.
Okay, I was gonna ask you. What's a berry
Berry aneurysm is just the name of a saccular aneurysm. So you gotta get.
Like, does it look like a berry or does it cause like?
It looks like a berry. That's the idea. It's not caused by berries. That would be terrible. Like, imagine getting a stroke because of a berry.
Yeah.
That would suck. Alright. I hope that never happens again. Shop. Okay. And then Charcot-Bouchard, like we said, this can happen. Intraparenchymal hemorrhage, hypertension, and lenticular striate arteries are other associations. When you do angiography, what's angiography?
You see that
You specifically look at the blood vessels.
Yeah.
So in the brain, we look at the cerebral angiography, we look at the blood vessels of the brain. The idea is in Charcot-Bouchard aneurysm, you won't see anything
Wait, why?
because it's not part of the main brain supply. It's bleeding inside the brain. So yeah, it's very difficult to see one in angiography. But that's an interesting feature of it. Heat stroke is not a stroke. It's just your body can't dissipate heat, and it causes CNS dysfunction, but it's not a stroke. If you don't treat it, though, it'll be worse than a stroke. Okay, brain herniation. So right here, you have, this could be a subdural hematoma, for example, compressing the brain structure, pushing it. The idea with these is you have four. You have cingulate, central, uncal, and cerebellum. Right? Let's start off with the best and the worst. Which of these do you think is the most okay?
No,
No singular.
Singlet, yes, singlet is fine. And not really, but like relative to the others, it's okay. يعني ماشي. طيب. Singlet, the idea here is all it does is compress the anterior cerebral artery. What does that mean?
No.
Yeah.
Anterior is weak.
No, it's a medial part of the brain. So what symptoms will it produce?
Contralateral.
Contralateral, what weakness? Lower limb weakness.
Yeah.
Exactly. So that's singlet. That's all great. Maybe the patient dies, maybe the patient lives, who knows? But it itself, and the symptom of it itself is just anterior cerebral artery compression without pupil signs. The worst one, which one do you guys think it is? The last one. Literally, the patient just dies. How? The entire brain goes down, and this is called a tonsillar herniation. The entire brain is pulled down, and it kills the patient.
Wait, the whole brain?
This is when you do a lumbar puncture when you don't need to. And you
It can happen when you do an unnecessary lumbar puncture if you didn't rule it out.
why does that prove spinal?
Exactly, because the pressure difference, the brain herniates. Yeah, so be careful. And it just causes cardiorespiratory and cardiopulmonary arrest, and as a result, patient dies. It can cause a coma before death, but it's really bad. Then we take the other two, right? Central versus uncal. Both of them will have pupil signs, right? So ipsilateral dilated fixed pupil, and then bilateral fixed pupils. So central will have bilateral pupil abnormalities, whereas uncal will have one side. Right? So uncal, uni side, central, maybe because it's in the middle, causes both. Weird ways of thinking about it, sure. And then uncal also has progression. So early, it will be contralateral weakness, which becomes ipsilateral weakness. And then with central, you'll see, rather than weakness and all that, you'll see posturing. And we'll talk about posturing in the next slide. Okay, so let's recap. Cingulate, sorry, is what's not called. Because the idea is it's the easiest one, anterior cerebral artery compression. So tonsillar, worst one. Now, this one we can say worst because it's terrible, like coma or death. Uncal, one-sided, so uncal will be one-sided, so it will have ipsilateral dilated fixed pupil, dilated mispositioned pupil, and it will also have progression. So it will go early contralateral, and then it will become ipsilateral as well. وبعدين central, this one will have bilateral, and then it will have posturing. Right? I know it's a lot, so you're just going to have to bear with me. Last thing is abnormal posturing. I actually think this is my last slide before questions, and we'll be done. But we really got through it quickly, I guess.
Yes.
So we have the corticate and the cerebellum. So I want everyone to participate with me. Put your arms like this. This is the corticate, and then like this, the cerebellum. All right. The idea here. Thank you. You can put your hands back. But the idea here is the corticate is called flexor posturing, and the cerebellum is called extensor posturing. So the corticate, your arms are flexed, your legs are extended. Yeah, exactly. The corticate. So you're taking it to your core. And this is in lesions above the red nucleus. Right? It can affect the rubrospinal and vestibulospinal tracts, but remember, lesion above the nucleus, above the red nucleus. The cerebellum is at or below the red nucleus, and it causes both of them to be extended. Right? So your arms are extended, your legs are extended. The reason I included this thing right here, do you guys know what this table represents?
Yes, that was
So tell me about the Glasgow scale.
It's a scale to measure how cognitive the patient is, and the least score you can get is 3.
Exactly. 3 means you're dead.
Yeah.
Perfect. Play. Go ahead.
You said that the lower limb would be extended.
Lower limb is always extended, but it depends on the upper limb.
So here it says.
I wrote it wrong.
Okay.
No, that's on me. I'll send you guys the corrected version, inshallah. I don't know why it said. I swear I wrote extended, but it should be extended.
Thank you.
Just look at the pictures right here. Like if you do it while you're standing, for example, you're extended already. So that's the idea. So the idea behind showing you guys the Glasgow scale is essentially the corticate means 3 in the motor, and the cerebellum means 2 in the motor. So let's say you had a guy with no response to eyes, no response to verbal, but he has abnormal extension. He has, for example, the cerebral posturing, and they ask you to calculate the Glasgow scale. 4.
Wait, I got confused.
So no response to light, no response to sound, the cerebral posturing. What's the Glasgow scale?
So 1, 1, and abnormal extension.
2.
Yeah. So the cerebral, you see abnormal extension. This is the cerebral. Abnormal flexion. This is the corticate. So the idea is, if I tell you the cerebral and does not respond to verbal or eye opening, what's the Glasgow scale?
4. 1 4.
It's 4. Why is it 4?
Because 1, 2.
Very good.
Oh.
There's no 0.
There's no 0. Exactly.
Oh, okay.
Yeah, so you add.
So yeah, the idea is, if I say if there's a question that says the cerebral, motor means 2. Motor response is 2. If the question says the corticate, 3. What if they tell you he has flexion of his upper limb and extension of his lower limb? The corticate.
So 5.
Exactly, it would be 5. And let's say they tell you he has extension of both his upper and lower limb. 2. So total score?
4.
Very good.
If it's not responsive, how is it?
Sorry?
Motor response, there's no response. Like
0
Isn't,
in each one.
isn't it naturally extension?
No, and you touch him, and then he starts extending.
Oh,
The idea is you see the motion. They're not postured like this. Just you, for example,
you stimulate them.
you touch them and they go like this. That's the idea. Does that make a little bit more sense?
You touch them and they go like what?
Like the cerebral is, if for example, let's say the patient's lying like this, so they'll extend their arms, right? And when you touch them, that means they have the cerebral posturing. And is this above or below the red nucleus?
Below.
Below or at the red nucleus? And then above the red nucleus would be which one? Good, cool.
So these are midbrain lesions.
Yeah, they are. Essentially, they are. Yeah, they're midbrain.
And when you say above, most of the cerebrum or the cerebellum, and they give us the cortex.
Not the cerebellum, but it could be something at the cerebrum level.
Okay.
The cortex can happen at the cerebral level. The idea is it happens because there's something above the red nucleus. When we say decerebrate, this is brainstem. Okay? The problem is in the brainstem. So excellent points. Like, did we understand everything that we talked about?
Yep.
I know we said a lot of words. I know we spent a decent amount of time. But I think, I hope it's all clear. في كثير أشياء you don't need to know for your midterm, but in terms of your step exam, I has covered everything. We do have 10 questions. So there's a decent amount of people here, so I want different people answering. So we'll start off with this first question right here. You have a 65-year-old man with chronic alcohol use. Presents to his primary care clinic. 2 years ago, hospitalized for confusion, vision loss, gates, resolved with thiamine repletion. Since discharge, he has continued to drink alcohol heavily, developed progressive forgetfulness, and cannot recall recent events. When asked questions, he responds confidently with incorrect answers. The case scenario above most likely corresponds which of the following disorders? It's Wernicke. So is he in Wernicke or Korsakoff?
Korsakoff.
Why?
Because of the
He's
alcohol.
answering incorrectly.
Exactly. Confabulation is the word. And basically, they're making up things and they believe it's correct. So, Wallah al-Azim, I'm the king of Georgia, for example. ويحلف بعد. Now, why he's drinking alcohol, احلفing, that's confusing. Whatever. Anyways, next question. 70-year-old man presents the emergency department with confusion after having a convulsive episode. Prior to having the seizure, the patient reported having a progressively worsening headache that awoke him from sleep and right-sided weakness over the course of 7 months. On physical exam, there's a weakness 2 out of 5 strength throughout the right side and the left pupil that is unresponsive to light. A CT scan of the head shows a ring-enhancing lesion surrounding the cerebral edema. Which of the following herniation syndromes does this man most likely have? Why?
Because I don't remember.
It's not tonsil.
It's not tonsil.
It's not tonsillar, it's not cingulate.
Yeah.
Great. We know that.
So it says uncle
Uncle
is
is unilateral, central is bilateral.
There you go, it's uncle.
Wait, say it again?
So uncle affects one side.
Can you review that again?
Absolutely. Okay. So the idea is tonsillar and cingulate you all understand, right?
Yeah.
Uncle sounds any if you take you at uni, right? One thing. So it affects one side, one pupil. And the idea is initially starts as one-sided lesion and then goes contralateral.
Wait.
Sorry, it starts contralateral, becomes
Yes.
ipsilateral. So it becomes full body paralysis. But it starts off with one side. With central, it's posturing, and then on top of that, there's both pupils are fixed and dilated.
And they're not low.
And they're not both.
Keyword.
The pupils are not absolutely.
Yeah.
Does that make a little bit more sense?
Yes.
Okay, great. Okay, next question. A 51-year-old man, actually just read the CT.
Very extreme.
Yeah.
So it is A.
It's epidural.
This is
So back side.
It's banana.
Can you go back? Subdural.
Very good. It's subdural banana. So does anyone know what Gronkowski's anomaly is? I made it up.
Really? Are you serious?
Gronkowski, does anyone here watch NFL?
Yeah.
Yeah. You know Gronkowski?
Yeah.
Well, he's still, him and Brady are still retired, صح? Yeah. So basically, there's a team in American football called the New England Patriots. They had Gronkowski and Tom Brady. They got bored. They retired initially after winning 5 championships, which is a lot. They got bored of retirement, and then they decided to go back to a different team that was doing terrible. Won 2 more rings, and then they retired again.
And then they're like, okay, now we have Gronkowski. He made that.
No, I made up Gronkowski.
Oh, so what was the story for?
I know where you got it.
So where did
Oh.
Where did Gronkowski come from? Now, why did I include Gronkowski? Honestly, I was watching a TikTok about him. He's very funny. Anyways, all right. Which of the following shows a patient who is eligible for TPA?
The A, the first one.
This is the only one.
So is it A, B, C, or D?
A.
He is hemorrhagic.
It's
D is a scheme. You don't give TPAs.
Yeah, you don't. Yeah, it's an A.
Eligible.
yeah, eligible means that it's
So who do you give TPA?
You can't give
D.
hemorrhagic. It's
You give D.
Oh, I said D.
This is Wernicke-Korsakoff. Mammillary bodies. There's no ischemia. Dark is ischemia.
Exactly.
Oh. I was.
So in imaging, the dark is ischemia.
Sorry.
This dark area, right? This is literally the same image. This dark area over here is ischemia.
Yeah.
This right here
Oh, yeah.
is calcification.
Ischemia, so we have a blood clot. TPA
The-
will break the blood.
Absolutely. All right. Yeah. Okay.
Why is it until S?
It's most likely affected.
Well,
A.
Wait. This
Ah,
is
for
wait,
this one?
wait.
This is the middle, yeah. This is B.
MC and B.
Yeah, it's MCA.
Why did you put every single blood vessel together?
Because sometimes they'll do this to you in exams, where they'll put so many. No, not this many.
Why is wrong?
I remember one. Like, there's one where I saw up till J, but so I was like, you know what? I'm gonna be better than the exam. I'm gonna be even worse than the exam. Yeah, and just get a load of this guy. Anyways, 65-year-old woman presents the emergency department with meaningless speech.
See,
Meaningless speech.
No, wait, look.
The patient was in her usual state of health until 3 hours prior to the presentation, where her daughter noticed her mother having strange speech. On physical examination, her speech is fluent and has paraphrasic errors. In comprehension repetition is okay. In visual field testing, there is right upper quadrant field cut. Which of the following describes the most likely issue with the patient?
Wait.
Give you guys a minute here, because it's a lot of words.
Strange speech that she's not making sense.
Meaningless, but
She's fluent.
It's not broken.
it's fluent. Her speech is fluent. This is broken.
Repetition is impaired.
Apparently,
No,
this is
fluent
C.
is word.
Oh, yeah, because it has both. Let's see. Yeah. Repetition is.
I do not understand.
Wait.
Okay, is the patient fluent?
Yes.
Does the patient understand?
No.
Yes.
Yeah.
Oh, no.
What? How do you know she understands?
Comprehension is
Strange speech means she doesn't
The
understand.
patient is not.
So they literally tell you guys the speech is fluent, but the comprehension repetition is impaired.
So B.
So it's
Let's take you guys back to the table. So yeah, it is B. Let's take you guys back to the table, because I know it's confusing. Look at this table. Fluent, but can't understand. Wernicke's. If they're fluent and can't understand, it's conduction. If they're not fluent but understand, it's broken.
It's fluent. Oh, yeah.
so.
They say words, but the sequence of the words doesn't make sense in Wernicke.
I have a question.
Sure.
If they can't repeat, it also goes under Wernicke. So it's not just about conduction.
So poor repetitions for all of these.
It's all of them.
So I told you guys, ignore transcortical. All of these aphasias have poor repetition.
Because we took that repetition is associated with conduction.
For all the aphasias you need to know, they all have poor repetition. So let's go back. So what was your final answer?
Wait.
Absolutely. Why?
Because can't comprehend, but fluent.
She's fluent, but she's not aware of it.
So she can speak, she can't comprehend, and she can't repeat.
Global vision is when both of them
Global aphasia is when nothing works.
are nice.
Not every. كل شيء خطأ. Later. What if I told you guys her speech is influent, but she can't comprehend?
Influent? That's broken.
Influent, but can comprehend.
Yeah.
Broken. So they can't produce speech, but they can understand. Broken, because bro can't talk. And then let's say I tell you guys their only issue is repetition.
Conduction.
Very good. Broca is in what lobe? And Wernicke's?
Right. Temporal.
Temporal.
Wait. Broken?
Broca's is frontal. Alright, let's try this one.
Wernicke's is temporal?
Wernicke's is temporal, yes. Let's try this one. Just look at the CT.
It looks normal to me.
Me too.
Wait, there's no.
B.
Wait, is this Willis?
This is subarachnoid. This is air headache.
Most severe headache?
Subarachnoid. This is the worst headache she's ever experienced.
You said don't read the question. Is it?
You guys can read the. I'm not. No, I'm saying you could just look at the CT and then read the question.
Yes.
Also, this is
Very.
subarachnoid.
Yeah, very.
Very.
I don't know what a very.
I have never heard of that one.
Subarachnoid.
It's Harvard. It's the worst thing. What does the CT show?
I don't know.
CT? I have no idea.
Okay, what did I say the CT appearance for subarachnoid would be?
It looks like
No, that was
Should
Oh, that
we
was
take
a
a
very-
very.
parenchymal. This I said for subarachnoid is enhancement around the circle of Willis, because the aneurysm is in the circle of Willis. And I said the most common location of the aneurysm was the anterior communicating artery.
I didn't exactly.
Right.
Oh, okay, interesting.
The idea it looks like an eye as well.
Yeah.
But let's say we didn't have the CT. Forget the CT.
Worst headache.
Forget that. Knuckle rigidity.
What's that?
Neck stiffness.
Oh, right.
Knuck- Meningismus.
Oh.
Knuckle rigidity is neck stiffness. But you could ignore all that. This patient has meningismus without a fever. That doesn't mean it's not meningitis,
So it's not
but that's not an option. So it could be subarachnoid. And if we did a spinal tap, what's the feature we see? Xanthochromia. Very good.
Five. So it's
Wait.
Wait. Don't answer.
This is the red nerve.
it's above
No, wait, yeah. It's above the.
Final answer?
Above the.
D.
It's cord to
cortical effect.
Yeah, it's above the red nucleus. Very good.
Decortical.
Thank you, guys.
Thank you.
Are we done?
Where are you
Done?
on PowerPoint?
Sorry?
I do. Oh, this is Wilson's.
Wait, you didn't put your dog. You usually put your dog.
Yeah.
Where is
They need to like, this is my dog.
No, that's for any psychiatric
What's
PowerPoint.
your dog's
Apollo.
Why don't you want to involve your dog in brain tumors and hernias?
I would repeat the sentence and understand. But yeah, okay, well, that's it from my end. Does anyone have any? Do you guys understand?
Yeah.
Yes.
Do you,
Show us like where the piece of aphasia is.
It's so weird.
I'll try.
Yeah.
Well, I'll try
Oh, you
find the
said you'd
video.
show us something.
Well, I was gonna show you guys the cerebellar. First of all,
Wernicke's is like you're like.
Giga, where is it?
I
Look how cute he is.
Oh yeah, we have this whole picture.
Right here.
It's in the pink slide.
Oh yeah.
Look how cute that is.
That's.
Oh my
That looks
God.
like a lizard.
It looks like an axolotl.
Yeah. We did see that. It wasn't the.
I didn't see this.
It's in the cerebellum.
Oh my God. Look at that picture. Look at it.
So, in terms of like examples of Wernicke's and Broca's aphasia, I'll look for them on YouTube. Honestly,
Search them all and find
we'll try to search them. Let's see
You
YouTube.
go YouTube and then type videos.
All right, here's an example.
Yeah, that one. That's one I want
Here.
to watch.
I don't know if this is an explanation or anything.
اكتشفوا نكهة جديدة.
Yeah, let's try this one. You're not paying for YouTube Premium. Like other than that, does anyone have any questions? Because we have a bunch of ads.
Can you reach the wall?
I can. If I know.
Hi, Byron. How are you?
I'm happy. Are you pretty? You look good.
What are you doing today?
We stayed with the water over here at the moment and talked with the people for them over there. They're diving for them at the moment. They'll save in the moment. He'll have water very soon for him.
Okay.
With luck for him.
So we're on a cruise and we're about to
We
get to
will
Juneau.
store it right here and they'll save their hands right there for them.
And what were we just doing with the iPad?
Right at the moment they don't show a darn thing.
With the iPad that we were doing.
Isn't the room upstairs? Ah. Okay.